It's with great pleasure I introduce this research lecture being given by my friend and colleague, Dr. Robert Sitrin from the Department of Internal Medicine, the Pulmonary and Critical Care Medicine Division. He is going to be talking to us about an area that's near and dear to our hearts in spinal cord injury, and that's sleep-disordered breathing disorders, a problem for which he has been working with our team and has taken the lead on obtaining a Department of Defense grant so that we can really study this in earnest in our patient population. I know in talking to centers around the country, this is a problem that is relatively under-recognized and under-evaluated nationwide. And yet, as he's going to talk about, the implications of this disorder are very significant. Just as his background, he's Michigander by training, both undergraduate and medical school and residency. Did his fellowship at the University of California, and I'm not going to give you dates because that's just totally unfair. And but
early in the McKinley administration.
But he's been back here at the university. He's a full professor. He has a very distinguished clinical and research career, and it's been a pleasure working with him for the last 2 years as he's really taken this area of respiratory dysfunction and spinal cord injury and has given it real meaning here at the university, and I'm looking forward to his talk.
Thank you. Oh, in advance. Thank you all. This talk is shameless advertising because my main goal here is to make you all aware of the upcoming study and get you all fired up for being in love with the topic for the next several years. That's my disclosure statement, and after the fashion of many of my role models, I declare myself to be a thoroughly honest person. There'll be a quiz afterwards if you recognize everybody. Most people don't. So, I think there's some general, people have some general exposure to what sleep apnea is all about, but I think a good place to start is to just give you a base of what's known about sleep apnea in the general population, and I think that sort of sets the stage for spinal cord injury. Most of the time when we're talking about sleep apnea, we're talking about obstructive sleep apnea, which means that during sleep, usually the deeper stages of sleep, breathing either stops or slows down because of partial or complete closure of the upper airway despite continued attempts to breathe. That's the definition of an obstructive event. Most of the literature describes sleep apnea by the apnea-hypopnea index, or AHI, and I'll be talking about AHIs throughout the talk. It's a pretty simple index in its basic form. It's basically the number of times you stop breathing or slow down the breathing rate, the inspiratory flow rate, I should say, by 50% or more. For 10 seconds, the number of times you have 10-second episodes or longer per hour of sleep. Now, nothing could be that simple. Apnea is always defined the same way. You're not breathing at all for 10 seconds. Hypopnea is not always defined the same way. Most people define it as at least a 50% reduction in airflow. But that's not uniform through the literature, as I'll show you, and it creates some of the problems with using AHIs. And not every sleep study uses the EEG to physiologically define the sleep period. Some studies will define the sleep period as lights out till lights on, which is okay, but that's not really an AHI. Most people are careful to call that a respiratory disturbance index, which is perfectly valid, but you have to understand when you have these indices what your numerator is and what your denominator is. The symptoms are common and nonspecific. Snoring is the most common, but there are many more snorers in the world than there are people with sleep apnea. People complaining of restless sleep, the resuscitative snorts and gasps, which can be dramatic and wake people up many times during the night, scare the hell out of their bed partners. If it's bad enough, daytime sleepiness, generalized fatigue, and poor concentration. the prevalence is sort of how you define it. If you just define an AHI greater than 5 as sleep apnea, 20% of the adult population has sleep apnea. If you tack onto that any of these symptoms, then the prevalence is somewhere around 2 to 9%, but it's not uniformly distributed. If you're over 65, the chance of having sleep apnea is 2 to 3-fold greater. It's more common in men than women, so older men, easily the prevalence is over 20-30%. That's clinically important sleep apnea. There are many risk factors, obesity being the most common. Large neck circumference actually has pretty good predictive value. If you're an adult male and your shirt size is greater than a 17.5 collar, you probably have sleep apnea. There are hereditary factors, chronic nasal congestion, diabetes, smoking, congestive heart failure. All of these are well established. Any craniofacial anomaly that would compromise the upper airway. So the most common being a short mandible, or anything that is related to underdevelopment of the midface would compromise the upper airway. And this is not only important because of the symptoms. There's a lot of morbidity associated with sleep apnea, as I'm sure you've heard. If you have severe sleep apnea with an AHI over 30, there's a 3 to 6-fold increase in all-cause mortality and increased cardiovascular risk. Specific associations, if not clear cause and effect relationships, with systemic hypertension, pulmonary hypertension, coronary artery disease, cardiac arrhythmias, several different kinds, nocturnal sudden cardiac death, ischemic stroke, diabetes or a pre-diabetic state, and accidents including motor vehicle accidents. I'll come back to that. The pathophysiology is complex, but one thing we agree on, the world agrees on, is that obstructive sleep apnea is associated with sympathetic hyperactivity. When you have an apneic event, by the time it's over, there's a surge of sympathetic activity such that by the time that the event is over, your systolic blood pressure can easily top over 200, at least transiently. And eventually this spills over into sympathetic hyperactivity even during the daytime. There's also evidence for a stress-induced cortisol release, which may be the relationship with diabetes or a pre-diabetic state. But this is a little less clear because you can get a lot of these same effects just from simple sleep deprivation. So you could argue whether any sleep deprivation, or is it specifically related to sleep apnea. Now, central sleep apnea I'm not going to talk about very much because it's much less common. This is probably an overestimate. This is where the upper airway is patent, but you just lose your drive to breathe and you have long pauses in your breathing, longer than 10 seconds. There's some overlap in the demographics in that it's more common in elderly males, but this is much more specifically related to congestive heart failure, post-stroke, and a few other conditions. For example, if you have moderate to severe congestive heart failure, 50 to 70% of those patients will have some kind of central apnea, either isolated pauses or something more complex like Cheyne-Stokes breathing. And there are some studies that show that after an ischemic stroke, at least transiently, as many as 20 to 30% of patients have some central apnea as well. The symptoms are much more subtle and unreliable. They overlap more with congestive heart failure, so people will only complain of daytime fatigue or orthopnea. But neither of these conditions are benign. Both obstructive and central apnea increase the mortality associated with congestive failure. All right, so let's get to spinal cord injury. Here it's a little bit more complicated because here the sleep-related breathing disorders come in 3 delicious flavors. There's obstructive apnea, which, as I'll show you, is very common in cervical cord injury. Central apnea, which is probably very uncommon. There are scattered reports that go back 20, 30 years of somebody who has like a severe whiplash injury but with motor recovery, and then they've had some central apneas noted, or some procedure, a patient with central apnea that has decompression of the upper cervical cord and then the apnea goes away. So this is probably not important in the larger context of what I'm talking about, but there really isn't much data about it. And then the third form of sleep-related breathing disorder, which I think is the real elephant in the room, is non-obstructive sleep-related hypoventilation. Patients have weak muscles. They have a restrictive defect. When the lights go out, they lose some drive to ventilate, because everybody does during sleep. They just breathe shallowly, and even though they have a patent airway and they have some ventilatory drive, it's just inadequate to drive those weak muscles to keep an adequate minute ventilation, and the result is nocturnal hypercapnia. And I think a lot of what's been called, as I'll show you, I think a lot of what's been called obstructive apnea in the literature is actually this. Sleep studies are the gold standard for diagnosing all of these disorders. A standard polysomnogram, there's a lot of stuff, as I'm sure many of you know, that I'm not going to talk about. There's EEGs and EMGs at the chin, and surface EMG at the diaphragm, and sensors to detect leg movement. There are all kinds of things that are done in a full sleep study that aren't relevant to this talk. But from a pulmonologist standpoint, I ignore all that. I go to this. So we're looking for airflow at the nose or mouth as evidence of breathing. We're looking for some motion of the chest or the abdominal wall as evidence of effort to breathe. We're following oxygen saturation, and usually that's it. If you just order a plain sleep study, that's all you're going to get. Following the CO2 at night is not routine. You can ask for it, and usually what's done in almost every sleep lab is continuous monitoring or spot checks of end tidal CO2s. Basically, at end expiration, you capture the CO2 content of the exhaled breath, and the presumption is that that correlates with arterial CO2. It's not as accurate as other measurements. It's, if you have parenchymal lung disease, that assumption doesn't really hold, so it's not terribly accurate if patients who have had multiple pneumonias or chronic collapse of their lungs because of scoliosis or whatever. And it's touchy, it's fussy. You know, the system needs to be checked, and leaks and all kinds of things will mess up the measurements, so you just can't turn on the monitor, walk away, come back 8 hours later and expect to have 8 hours of CO2 monitoring. And a lot of times when I order this, I'll get a comment on a sleep study that says, well, you know, it was a 6-hour study and we got CO2 monitoring for an hour and 10 minutes, and we're not too sure about the measurements, but here they are. So not really, not optimal. One of the huge problems, you know, I presented the obstructive versus central, you know, versus neither. It's easy on a slide to present these as separate categories, but in reality, in patients with spinal cord injury, it may be very difficult to distinguish these. If somebody has respiratory muscle weakness such that their flow rates are low to begin with, detecting a 50% reduction may be very, very tricky. What may be obstructive or look obstructive may actually be non-obstructive at all. And I think that's, as I'll show you a specific example, but I think that's where a lot of the problem in the literature lies. And then what I learned, I didn't know this really until we opened our clinic, is that you order a sleep study for our patients and they just politely or otherwise say no. The logistical obstacles for severely disabled patients are huge. Just recently, you know, our sleep lab, who swears that they're bending over backwards to help us, they just refuse to do one because they have no Hoyer lifts. They won't provide personnel to transfer a patient. So basically, you have to come with enough people to lift and transfer you, or you don't get studied. And you know, if you ask things like, well, where are my caregivers going to sleep? Blank stare. What about my bowel program and my bladder program? Gasps of horror. So, you know, asking a patient to get a sleep study, you know, this is their mental image. That's the sleep lab up there. And I picked this image because there's no road. So, you know, part of the problem is that most of these patients go undiagnosed. No matter, it doesn't matter whether we really are aware of the problem or not. And you can't treat sleep apnea unless you pay for it yourself. You can't treat sleep apnea without the diagnosis based on a sleep study. So, Rock, I'd like you to meet the hard place. So Let me just go through what we know about the prevalence of sleep-related breathing disorders and spinal cord injury, and then we'll get into the grant. There have been a lot of surveys for decades, something you know better than I do. People with spinal cord injuries don't sleep well for a lot of reasons, and they have a lot of the symptoms that I described before that are consistent with sleep apnea but nonspecific. There are a lot of studies, both retrospective, oh, that was noisy, and prospective. Generally, the prospective studies are small. They're confined to inpatient or sleep lab settings. They tend to favor patients that have cervical injuries and motor complete injuries. So if you have a lower level injury or an incomplete injury, there's just not a lot of data that applies to you. Most people are studied soon after their injuries, and because the point was to do the research, not to find something that was clinically applicable, these are done in sleep labs, which is quite a selection bias right there. Before I get into some data, let's talk about pathogenesis. 10, 15 years ago, the party line, I stood up at some podium and said it myself, patients with neuromuscular respiratory failure are at high risk for sleep apnea because of weakness of bulbar musculature, but patients with spinal cord injury are spared that problem because their bulbar musculature is intact. It was a great story. We said it for years. It turned out the only problem with it is it isn't true. So after studies showed that, yes, there is a lot of sleep apnea, then we had to come up with reasons. And what I'm going to tell you is there are a lot of reasons. Not a lot of proof for any of them, but it's probably multifactorial. The first one is pre-selection. As I said earlier on, if you have moderately severe sleep apnea, you're at risk for accidents, including motor vehicle accidents. So it only makes sense that if you have a population that already have a spinal cord injury, it would be enriched in people that might have had sleep apnea beforehand. I only know one study that's tried to address this. This was a study in Australia where they took people who already had a cervical spinal cord injury and they questioned them about their pre-injury sleep apnea symptoms. So it was a test of memory, but they took those symptoms, they combined it with their age and their gender and their body mass index, and they applied it to a predictive model. And based on that, they said 10% of their patients probably had sleep apnea before their injury. So if you accept what I said before, that 50% plus or minus of patients with a spinal cord injury have sleep apnea, and 10% of those patients had their sleep apnea before their injury, the pre-selection effect is probably pretty big. But we don't know much more about that. Increased neck size. I talked about neck circumference before. Several studies that show that over time after a spinal cord injury, neck sizes increase, in part because of hypertrophy of accessory muscles. A lot of people have suggested that unopposed parasympathetic input to the airway mucosa causes upper airway mucosal thickening and narrows the airway. I put 2 question marks on this one because this is just a favorite idea of mine, but this hasn't been studied at all. I've talked to Tony about this. I think this would be a great project for somebody. I hope we can get somebody to do this. But the concept is that if you have pedal edema, as a lot of patients with spinal cord injury do, when they lie flat or recumbent at night, the edema rapidly resorbs from their lower extremities. Part of it is distributed rostrally to the neck. So this has actually been shown in about a dozen studies in patients with congestive heart failure. Within a couple hours, the ankle circumference goes down, the neck circumference goes up. And that could compress the airway enough to contribute to sleep apnea. And in fact, in one of the pulmonary journals about 2 months ago, there was a study of patients with proven sleep apnea and had pedal edema just from venous insufficiency. So the big intervention was they just gave them off-the-rack compression stockings and said, here, wear these. And just with that, the overnight increase in the neck circumference went down by 60%, and the frequency of their apneic events went down by 36%. So thinking back to all those patients in clinic with sausage-like legs that go down partially at night, I think this is going to turn out to be an important mechanism as well. Other ones that are not terribly specific to spinal cord injury, sleeping supine, as a lot of these patients do with infrequent turning. increases the risk, as does obesity, sedative medications. If the patient is chronically hypercapnic, that has a sedative effect. And if they have a concomitant traumatic brain injury, that may contribute as well. And just hypoventilating because of respiratory muscle weakness may bring out borderline sleep apnea. If you think of inspiratory flow rate as a balance between resistance and inspiratory effort, if you have almost enough resistance in your upper airway to restrict airflow, but you have normal muscles, you may not have sleep apnea. But if you're not generating much inspiratory effort, that may tip you over to having an apneic event. And even just breathing at low lung volumes, decreases the longitudinal traction on the central airways, and that actually causes the pharyngeal dilator muscles to be less effective. So just hypoventilating can bring out obstructive apnea as well. So it's complicated. I'm just going to show you briefly two studies that I think are the two most commonly quoted arguing for high incidence of sleep apnea in these patients. This one was from Montreal, and it's an anomaly because they actually hauled the sleep lab to the patient's home. So all of these issues about access and is the home environment authentic, or the sleep lab environment authentic to the home environment and so on, those issues went away. And they diagnosed sleep apnea on the basis of the polysomnograms plus symptoms. This just shows the demographics and the distribution of injuries and so on. And this is pretty typical, and you know better than I do. But as you can see, not a lot of patients with lower level injuries or incomplete injuries. It's just the nature of the beast. And at 41 subjects, that's a fairly large study. So what they saw was 23 out of those patients had an AHI over 5. All but one of those also had symptoms. So since they were using the obstructive sleep apnea hypopnea symptoms syndrome, 53% was the overall yield, and they didn't have it just a little bit. The average AHI was 27. The range is 5 to 96. 96 is just scary wild. Why are they still alive sleep apnea? And using some arbitrary cutoffs, 13 were mild, 1 moderate, 8 severe. So it was a pretty significant problem. This is the list of symptoms, and you can see the symptoms I described are very common. The problem is that they're also very common when the sleep study shows no sleep apnea. In this particular study, the significant predictors were daytime sleepiness, large BMI, large neck size, 3 awakenings per night. In this study and in most others, the level, severity, and duration of the injury did not predict the presence of sleep apnea. Everybody looks at baclofen and benzodiazepines because they're used commonly and they're an obvious potential risk factor. In this particular study, didn't correlate, but that's variable from study to study. So this is one of the studies, and I like this study because the studies were done at home. There was a wide range of time intervals post-injury. If any one study, I think, generates a credible number, I have the least problems with this one. This study was from Australia, and in many ways it's the polar opposite of the last one, but I think it's worthwhile going through briefly. This was a very detailed and intense study. These patients got 6 full polysomnograms in the course of a year. So you got to give them points for that. Because of that, there was a high dropout rate, and they only wound up with 12 patients going through the whole protocol. But such as it is. And they got a 60% yield almost immediately at I believe it was the 8-week time point. They actually had an 80% yield. So, whenever we want to cite an article that says high prevalence of sleep apnea, this is the one we all pull out. But it also points out the problems with doing these studies. They pointed out that over 85% of these events were hypopneas. In most studies, there's a larger percentage of apneas. So that sort of piqued my interest. And virtually all of these studies had an obstructive component. That didn't trouble me. But that got me to looking at the methods. Well, so what defined a hypopnea in this study? 50% reduction in airflow. That's commonplace, or less than 50% if associated with a cortical arousal. And they didn't really say how much less than 50% they actually got. So given that these patients have a lot of respiratory muscle weakness and their baseline airflows are really, really low, I just am very, very skeptical that a decrease in airflow at much less than 50% necessarily means anything, even if it's correlated with cortical arousal, and that may be contributing to this higher prevalence. The other problem is with this obstructive component. Their definition of an obstructive component is a hypopnea with evidence of diaphragm EMG activity. Now, if these were able-bodied subjects, I would believe that, yes, if there was EMG activity in the diaphragm, they were trying to breathe. The presumption is those muscles are strong. It was a legitimate effort to breathe, and if there really is a hypopnea, it probably is an obstructive hypopnea. But in this population where we know that they have respiratory muscle weakness, I defy you to explain to me how these criteria will distinguish somebody from an obstructive hypopnea on the one hand from, on the other hand, somebody who's just hypoventilating. They're making some respiratory effort. The EMG is, but they're weak, and it's just nocturnal hypoventilation without any upper airway obstruction at all. And I think a lot of what has kicked up this prevalence and what people have called obstructive hypopneas in the literature is actually just nocturnal hypoventilation. In this particular study, the AHI correlated with pulmonary function, neck and abdominal circumference, as he talked about. In this one, the benzo use seemed to be relevant, and the AHI actually went down when the benzos were DC'd. Not terribly surprising, but again, variable from study to study. So what do we know about hypoventilation, the elephant in the room? Well, for a long time, we really haven't had much data because all that was done was spot checks with blood gases in an inpatient setting or those questionable end-tidal CO2 measurements. This is one study that, probably the best thing I can tell you about this data is I've got the world's literature on one slide. That doesn't happen very often. This study by John Bach in New Jersey, but I think it paints a picture. This was a small study of 10 patients. They studied these patients 5 years apart. The first study was done an average of about 5.5 years after their injury. At that point, they all had normal daytime blood gases. About 60% had nocturnal desaturations. This study doesn't distinguish sleep apnea from hypoventilation at all. But at that baseline point, only 1 out of the 10 had nocturnal hypercapnia. 5 years later, even though the vital capacity improved a little bit, now one person has hypercapnia in the daytime. 50% of the patients had an increase in nocturnal desaturation since the first study, and now 3 out of the 10 have nocturnal hypercapnia. So it really suggests what we see in clinic all the time is that patients lose ground year by year or decade by decade, and it's not entirely clear why they do it. This may be sleep apnea superimposed on progressive muscle weakness, and is the muscle weakness due to neurodegeneration or the cumulative effects of all the pulmonary infections, whatever. Sort of as a corollary, I threw in this study from Baylor. It's the only study that goes really late out after injury, and they just showed a fall off in vital capacity at 10, 20, and beyond 20 years. So something's, again, happening late, but we don't know too much about this at all. All they could say in this study is that it wasn't related to smoking, and they only presented group mean data. So I don't know if this happens a little bit to everybody or if there's a subgroup that just crashes and burns and everybody else is staying stable. But it really suggests that some of these patients with nocturnal hypercapnia, with or without obstructive sleep apnea, we should be catching them or or they'd be developing this problem at 10, 20, 30 years out. Certainly not when they're in an inpatient setting. So that drives us more to thinking about studies in the home setting. So let me just finish this up by just summarizing what the patients with spinal cord injury have at stake with respect to diagnosing and effectively treating sleep-disordered breathing. Well, they have the same issues that patients in the general population have. There's the effects on longevity, risk of MI, stroke. Every study in the general population that looked at quality of life said, if you have sleep apnea and it's successfully treated, all kinds of quality of life indices improve. So spinal cord injury patients are probably not exempted from that. In addition, we know that pulmonary complications are the leading cause of death both early and late after a spinal cord injury, and it only makes sense if patients have sleep apnea or nocturnal hypoventilation. That could actually fuel the process of this progression over time. So maybe earlier diagnosis and treatment is actually going to slow that progression in that group of patients. And the last one, I didn't really lay much foundation, but and that's related to the metabolic syndrome. The metabolic syndrome is a catch-all that describes the combination of increased visceral fat, diabetes or pre-diabetic state, hypertension, and hyperlipidemia. We know that all of these things, at least these components individually, are common after spinal cord injury, particularly obesity. We know that all of these things are comorbidities that are probably the consequence and partially driven by sleep apnea, obstructive sleep apnea in the general population. What we don't know is, does sleep disordered breathing have anything to do with these morbidities in spinal cord injured patients? And that's part of what we want to address, at least in the short term in our study. So with all that in mind, we embarked on this about a year and a half ago to get this grant, and mainly to satisfy budget requirements and what they wanted to see in a study. The design is a prospective study of a 100-subject cohort. And the main goals are to look at the feasibility of a home-based testing strategy that I'll show you in a second, to diagnose both obstructive sleep apnea and nocturnal hypoventilation, and to determine the short-term benefits based on this diagnostic strategy. So we will be enrolling patients who are 18 or older, C1 to T6, for at least 3 months. And because there's going to be home studies, we want them within 100 miles of Ann Arbor, or as close as makes no difference. Just the usual exclusions, unable to consent and so on. Obviously, we can't study ventilator-dependent patients. There's also no point to. If patients were on non-invasive ventilation temporarily in the past, and it was at least 3 months ago, they're still eligible. So, if somebody was admitted for pneumonia and they got BiPAP'd, that doesn't kick them off at all. We're trying to be as inclusive as possible. Before I get into the actual methods, let me just give you the overall lay of the land. This is the timeline. The basic structure of the study is that we determine eligibility and consent patients at this first point, and then there's a 4-month run-in period where they're going to be keeping daily daily logs of their symptoms and certain events. So this will give us some baseline. We'll also be able to review their records and determine frequency of clinic visits, hospitalizations, and so on. At time 0, that's when they get a clinical assessment. Tony makes a pronouncement of the level and completeness of their injury, and we get some baseline weight and head and neck circumference and so on. We'll do spirometry. And then Armando in the back there will go out to their house and we'll do the home-based sleep study that I'll describe in a second. Based on that, if they have sleep apnea, hypoventilation, or both, we will prescribe BiPAP according to standard protocol, standard way we do things clinically. Nothing different for the research project. And then we're going to evaluate them at 3, 6, and 12 months with some follow-up labs and follow-up weights and blood pressures and so on. And then every 3 months we'll also check in on their symptom logs. So that's just the lay of the land. Let me just go through the methods. The quality of life questionnaires occur at 0, 3, and 6, and 12 months. This is a perfectly good time to jump ahead in my acknowledgments. God knows what I would have come up with if it wasn't for Marty Forsheimer. He helped me greatly choosing the questionnaires and how to structure all this. So the general quality of life questions come from the short form 12, version 2, 8 questions about the general state of their health, emotional state, impact of health on their activities, and so on. And 4 supplemental questions about their activities, recreation, whether there's a spouse or SO in the house, and we'll also ask about skilled caregivers. We slipped in 2 questions specifically about pain from the brief pain inventory, just how much pain do you have and how much does it interfere with your life? The justification for that was, 1, it just made sense. A lot of these patients have chronic pain. Sleep deprivation is a stressor that could contribute to more pain. And also there was 1 prospective study of BiPAP in patients with respiratory failure due to ALS. And one of the most striking things on the quality of life survey was just a dramatic reduction in their pain. It wasn't commented on, it wasn't explained, but I don't even remember what the scale was, so it means nothing. But with that proviso in mind, the average pain rating went from 150-something down to like 6. So I want to know if that's reproducible. And lastly, we're using the Epworth Sleepiness Scale, which is a standard instrument. It basically asks 8 questions about activities where you're relatively passive, and how likely are you to fall asleep when you're like riding in a car or watching TV or things like that. Our daily event log, we got some help from public health at telling us how to make this easy for patients. But basically, they just have a simple checklist with specific triggers. They will check every day. Did you have to do anything extra to manage your lungs? Increase your oxygen, increase secretion management, so on. Did you have to interact with a doctor about your lungs? Are you on antibiotics because of your lungs? Goosebump is the trigger phrase for did you have any symptoms of an AD reaction that day. Dizzy is the trigger phrase for orthostatic hypotension. I'll come back to that in a bit. And then we'll encourage people to check their blood pressure with these events, and was your systolic over 140 or less than 80. So what we're hoping is that we can keep, because we kept this simple, we're hoping that we can keep these records for the 4-month run-in and throughout the year of the study. So this is the home sleep system. This is actually commercially available. There's nothing terribly innovative about this. This is made by Respironics. It's called a Stardust 2 system. This is about the size of an iPod. It doesn't do EEGs, but it does the stuff that I really need. There's a thermistor to measure airflow at the nose or mouth, depending on where you put the cannula. There's an inductance plethysmograph band to just measure movement of the chest or abdominal wall wherever you place it. There's a pulse oximeter, and if you want to use it, there's an event monitor to track things like lights out, lights on, body position, and so on. There might even be a microphone to measure snoring, but we're not going to use that. And then we're going to couple that, this is an innovation, with this monitor, which is, we refer to as the Centec. This is, also has a pulse oximeter, which is a redundancy, but it's a transcutaneous capnograph. So instead of measuring CO2s in the exhaled breath, we just attach a probe to the skin, usually earlobe, anterior chest, just snaps on with an adhesive patch. And this actually is more accurate than exhaled CO2s. It's not limited by things like intrinsic lung disease and so on. I won't bore you with all the accuracy data, but plus or minus 5 millimeters, basically, this is as accurate as drawing an arterial blood gas and a lot less painful. We've been using one in clinic for home studies for the past couple of years. And just to show you the yield, this is where we got the idea to do this project. Even the patients that we have with severe restrictive lung disease, normal daytime CO2, not on BiPAP, as far as we could tell, doing fine, but with severe restrictive defects. When we did the overnight monitoring, 45% of them turned out to have nocturnal hypercapnia, enough to justify putting them on BiPAP. So we suddenly got a peek at what was below the tip of the iceberg. And then we said, well, geez, wouldn't it be nice if we could do a home sleep study with this? Then we'd have all bases covered. And it's very reliable. Armando sets these up and leaves, comes back and picks them up the next day. So we don't have to deal with the pain of a technician in the house all night long. And out of 38 studies that we're currently writing up, 35 of them went fine. Only 3 of them were considered suboptimal, so pretty good. If I piqued your interest, I'll tell you, just by way of warning, when I did a Google image search to find this monitor, a picture of it to show you, I found out there are 2 Centec companies. One is Centec AG that makes this. There's also Centec Reptile Enclosures, which is a different company, but if you do a search for Centec, you're going to look at a lot of really creepy pictures of snakes in cages. Just fair warning. Okay, so if the patients are diagnosed with sleep apnea or nocturnal hypoventilation, we're going to give them BiPAP, as I said, according to normal clinical standards. If they have strictly obstructive sleep apnea, we'll use BiPAP Auto, which just auto-titrates the settings designed to keep the upper airway open. But for most patients, when we diagnose hypoventilation, we're going to use AVAPS, which is just BiPAP, but it has a different algorithm that adjusts the pressure to maintain a consistent tidal volume. So, it will treat both nocturnal hypoventilation, and it provides the kinds of settings that will also treat sleep apnea. And then we'll be able to download a wealth of information from the BiPAP units, exactly how many hours a night it's used, the performance, what pressures it's achieving, whether it's leaking, if it's alarming, why. In case of BiPAP Auto, it even tells us the AHI on treatment. And then at 3, 6, and 12 months, we're going to do the follow-up monitoring with the Centec to make sure that their CO2s are under control. So in the last 5 minutes, let me just show you what the specific aims are, and then hopefully have time for a few questions. So the first aim is the obvious one. What's the yield of this home-based treatment strategy? What kind of frequencies we get for obstructive apnea? I think I went through the rationale adequately. But I think the real added value is going to come from the Centec monitor, because now we'll know something about nocturnal hypercapnia in addition to the obstructive apnea. So issues, limitations. One is the study size. We have no idea. I mean, this is one the added value of the study design, is that now we'll have some idea of how much overlap there is between obstructive apnea and just non-obstructive nocturnal hypoventilation. But depending on how much overlap there is, we may have some very small groups. What we would like to do is be able to compare normal versus just obstructive apnea versus just nocturnal hypoventilation versus both. But depending on the degree of overlap, some of those groups may be tiny if they exist at all. We're limiting ourselves to C1, T6. I'd like to be more inclusive, but we have to put some limits on because of the time and the limit on the budget. Because we wanted to design something that's immediately translatable, something that could be done in a cost-effective way, we're not trying to do EEG, but that means we have to rely on the sleep period, not the actual physiologic sleep time. I don't think this is going to be a problem. Where this introduces some issues is, say somebody has, 40 apneic or hypopneic events over an 8-hour period. So if they were actually sleeping for that time, and the EEG tells you that, they would have an AHI of 5. Okay? So you'd say, okay, you're fine. If they only slept for 4 hours during that time, they'd have an AHI of 10, and they would qualify as having mild sleep apnea. So there's a certain, not knowing exactly how much time they sleep, there is some uncertainty there. I'm not terribly worried about misclassifying somebody on either side of an AHI of 5. What I'm more concerned about is detecting people with a more severe disorder. And what we were seeing with the nocturnal hypercapnia studies, for example, is those people were hypercapnic for an average of about 50% of the study time. So if they tell us, I was up all night, I was watching movies, we'll repeat the study. But if they slept at all, we got under the tip of that iceberg. So I don't see this as a terrible problem. And lastly, we are going to use a very restrictive definition of obstructive events. We're going to try and stem the tide from misclassification of some of these events. So if a patient has a hypopnea, it has to be at least a 50% reduction in airflow. And we're going to say that if the respiratory effort, chest wall and abdomen motion, is preserved or increases, we'll call it obstructive. If it goes down at all, or if the flow rates or the chest wall motion is so low we can't tell for sure, by default we're calling it just non-obstructive hypoventilation. And the reason for that is because I want to bias towards detecting hypoventilation. That'll allow us to use the BiPAP AVAPs. Those settings will cover both hypoventilation and obstructive apnea. But if we diagnose obstructive apnea, the settings for treating apnea are much lower than the settings you need to really ventilate somebody. So what this does is it minimizes the chance that we undertreat somebody, although we would pick that up on the follow-up and adjust it accordingly. The second part of the study is just the feasibility. As I said, 35 at 38, we sort of know that the study yield is going to be pretty good, at least for the Centec monitoring. We'll get the diagnostic yield. We'll be able to estimate initial costs, but we won't be able to do a long-term cost-benefit analysis because we won't know the long-term benefits. We'll be able to look at the benefits over the first year. The second aim is basically to profile the patients according to their sleep disorder. So the rationale is we have all of these predictive factors for obstructive apnea in the general population. Other than a low FVC, we don't know what the threshold would be, but a low vital capacity in patients with severe weakness would suggest that they might be hypercapnic at night. Certainly a daytime CO2 elevation almost guarantees they have a nighttime CO2 elevation, but we want to catch patients before that. So we'll have all this data, the anthropomorphic data, the details of their injury, spinal or the spirometry, quality of life data, the symptom logs, and we'll be able to plug these into regression models and try and figure out if we can profile these patients and predict who has the disorder. The second part of this is to deal with compliance. Compliance is a huge issue in the general population. It's generally somewhere between 30 and 80%. That kind of range means it's kind of useless. As you can imagine, wearing BiPAP at night is not pleasant. It's intrusive. It's not like taking a pill, not that people are compliant with that. There are a lot of issues related to compliance. Equipment related, the mask is irritating, it's drying, they feel claustrophobic. BiPAP has advanced enough that in a recent Cochrane review, these have been declared to be no longer a factor in the general population. We can get past these. The problems with compliance relate mainly to the patient and their environment. So for years, people thought only people with severe sleep apnea will be compliant. Turns out that's not true. It relates more to whether or not they have symptoms that get better. There's their motivation. But it has to do with perceived health status, depression, a sense of whether they have control over their own life. Things like, if you've ever seen anyone wear BiPAP, there's no way not to look ridiculous if you look at yourself in a mirror wearing BiPAP. So people, what is my bed partner going to think of me if I'm wearing this ridiculous getup? And they're all legitimate concerns, but that's what motivates patients, and also the environment that they're working in. Have they been properly educated? Do they get reinforcement from their spouse? Do they get reinforcement from the caregivers? And I can tell you there's almost no literature at all on compliance in spinal cord injury. There was one survey done in Seattle, an average of 4 years after sleep apnea was diagnosed, and all they knew was 13% of the patients who were prescribed treatment for sleep apnea never tried it in the first place. 43% weren't doing anything. So maybe that's not too bad compared to the general population. No data at all on compliance when the indication is nocturnal hypoventilation. But, maybe you know this better than I do. I'd love some input from all of you about this. But my guess is that all of these factors, things we think we understand about the general population, none of them apply in the same way to patients with spinal cord injury. A little irritation of the mask may be huge, or a claustrophobic effect may be huge if you can't scratch your own nose. How would a patient who's already quadriplegic, in a power wheelchair, there isn't an empty AC outlet in the entire house for all the equipment they have, how do they react to introducing BiPAP? Are they going to say, that one more thing, I can't deal with it? Or are they going to say, pile it on? It's not going to change my life much. I have no idea. And the same thing, the environment. If you have a caregiver that's going to say, you need to use your BiPAP, and they're going to do that every night, and they put it on and say, find a way to take it off yourself if you want. It's a different input than somebody who's able-bodied and making that choice for themselves. So and we will have down to the minute, we'll know exactly how often the BiPAP is used. So we have a great opportunity to try and get a handle on this issue. Okay, just to wrap up, the second part of, well, this is basically what I just said, and we can address these issues. The real weak part of all this, we're not going to have detailed personality surveys and things like that, so we can't probe too deep into the psyche of why people are the way they are and making their decisions, but this will allow us to say something about whether it's related to the specifics of the equipment or their environment, or is it the patient. And if it seems like it's the patient, it would be a good hypothesis-generating exercise. And the very last specific aim is to look at the short-term benefits of BiPAP. The quality of life surveys, I went through in some detail. The second component is the pulmonary component. If they're using nocturnal ventilatory support, do they have fewer pulmonary complaints, fewer days that they need an intervention, frequency of antibiotics, frequency of hospitalizations, that kind of thing, whether it really changes the course of the progression of their pulmonary problems. I guess I'll comment on this very briefly. We slipped in this one sub-aim about blood pressure instability because of what I said earlier about this sympathetic hyperreactivity state. It only makes sense that if obstructive apnea causes you to have sympathetic hyperreactivity throughout the night and then spilling over into the daytime, maybe that will affect how patients behave in terms of autonomic dysreflexia or postural hypotension, although we really can't predict how we expect that would go. But we'll have those daily symptom logs, and we'll be able to track this. The mechanisms, some of these normal reflexes should be at least partially intact. Most of this sympathetic hyperreactivity comes from triggering the carotid baroreceptors. Those afferents travel along the glossopharyngeal nerves. So, the carotid bodies signaling your hypercapnic or hypoxic, which drives most of that sympathetic hyperreactivity. At least those afferent signals are intact. Also, there are direct reflexes. If you just are apneic, you hold your breath long enough, that will release normal sympathetic inhibition that comes from breathing. Also, at the end of an apneic spell, normally you hyperventilate, and that suppresses sympathetic activity. And if you don't have the muscles to hyperventilate, you would expect to have sympathetic hyperreactivity. So something really interesting could happen there, but we're not sure what it would be. And the very last is to look at those components of the metabolic syndrome that I talked about. And I guess that's best illustrated here, that at 3, 6, and 12 months, we'll have lipid profiles, blood sugars, blood pressure, and we'll be able to see if there are any short-term benefits there. So I have to conclude by once again acknowledging everybody in the assisted ventilation clinic that makes me look good. You know all these people. Armando, who many of you met, is our respiratory therapist and probably the person who can run this clinic by himself more than anybody. He's also going to be our study coordinator, thank God. And Christy Baumann, who's the other pulmonologist. I already thanked Marty Forsheimer, and I should acknowledge to Helena Schottland, who is new to the pulmonary faculty, and she's our sleep expert. She's going to be reading our sleep studies. So at that point, I will stop.
Thank you very much for this. Have you started the study, or when do you plan?
We are in the final. We have one more hurdle to clear from the Department of Defense, and the latest story they're telling me is that we probably will be approved to enroll people right after the new year. They said they would try and get everything to me by the middle of this month, but don't hold your breath before Christmas. So I'm expecting we'll be enrolling in January.
So when we think about the patients we have with spinal cord injury, folks we know, are we just looking for anyone or anyone with who may know about the study, or anyone with specific symptoms, or are you?
C1 to T6, if they're not already on BiPAP and they can consent, they're eligible.
Okay.
We're going to be using the spinal cord injury model system as our database, so we will be contacting people that we can identify as eligible based on the model system, but if they're not in the model system, but you think they're eligible, all we'll ask you to do, this is the hurdle I'm clearing with IRB now, is we'll ask you to just check with the patient and ask them if it's okay to get a phone call from Armando.
Okay.
You know, it is just as important for us to study people who fulfill the criteria who have no symptoms as it is to evaluate people who have symptoms. Because the only way that we'll be able to make any meaningful statement about whether there's an association of symptoms to the presence of hypoventilation or sleep apnea is studying enough people without symptoms and demonstrating that they don't have the problem. Because we have no idea whether or not people who are within this realm, who are at high risk just because of percentages, we have no idea if there are people who are lurking about who have no symptoms who actually do have a problem that we don't know about.
And when we're pulling the paper together,
I had no apparent symptoms that I was aware of. And just my wife said, you know, you stop breathing sometimes. It prodded me, and eventually I got a study. And I'll tell you, you know, with 85% hypercapnia over time, you know, the numerous episodes of arrhythmia, got my attention.
if it didn't get your attention, I admire your stubbornness. It's a good. Yeah, you know, I think one thing that we're going to learn from this study is that asking about symptoms is a good thing only because it conveys to the patients that we're interested in what they have to say. But in terms of making decisions about doing these studies, it's going to be useless. We actually, because when we were trying to look at our data on the Centec monitoring, it was a retrospective study, so looking at symptoms was problematic. But even at that, we could tell that the symptoms were pretty useless. And in fact, the other thing that turns out to be useless is looking at spirometry. The Canadian Thoracic Society just published another set of guidelines about neuromuscular respiratory failure, and they took some consensus-type safe guesses about, maybe you should think about a sleep study if a patient with this disorder versus that disorder have a vital capacity below this threshold or that threshold or a third. I don't think those are going to pan out as well. There are just too many exceptions. Of the patients that we looked at that had no nocturnal hypercapnia, the average vital capacity was like 38% predicted. And the people who did have hypercapnia, it was about 40% predicted. So forget it. I think what's going to come from this study is that this is a common problem, and the only way to get at it is to look for it and look for it in everybody, and probably look for it, I don't know, every couple of years or so. We'll eventually find out that, it's time for your overnight study, and that's how we're going to catch people, because I think the cumulative effects of being hypercapnic for, a third of your day, it's going to take its toll. And I didn't mention it, but, that sympathetic hyperreactivity thing, it's a big deal. When you read about the physiologic consequences of, in the general population and, as relates to stroke risk and myocardial risk, it's pretty impressive. And, one of the best ways to get a sympathetic surge or exacerbate a sympathetic surge from something else is to do it when you're hypercapnic.
It seems like age might be an issue here, and you have a very wide range starting at 18 and who knows, 85 or whatever we might have on the database there. Do you plan to control for issues of age, also metabolic syndrome, and medications? Because I'm assuming these are confounders in the design.
Yeah.
And do we have any options to have a control sample? That would be really the ideal.
That was one of the, so the question is, what's our control sample? this got into some very interesting questions. Fortunately, it was after the grant was funded. We had to justify things with the Department of Defense. And we basically said, within the confines of this study, we can't, well, first of all, we argued it's not ethical to identify a sleep-related breathing disorder at this point based on what we already know, as limited as it is, and not treat. And, how could you, even if you decided to not treat, you'd also have to do some blinding. And how do you put BiPAP on somebody for a year and blind them? Even if you use BiPAP with sham settings, people would know whether they're getting pressure or not. So, we basically argued that, as flawed as it is, there is no such thing as a control group, except each patient is its own control. And that's why we have the run-in period. And what we're going to look for is a change from baseline. So if patients who get treated with BiPAP, their blood sugar or their hemoglobin A1C falls or never rises, and that's not the case. We'll also have data on I'm sure we'll have people who are non-compliant or people who qualify but refuse BiPAP in the first place, and we'll continue to follow those. By the way, every time we have a one-on-one interaction with these patients, they're going to get $50. So it helps a little bit. So it's $250 for the course of the study. And, if we have patients that turn themselves into an untreated control, then, it's not perfect, it's not matched, but we'll have some sense.
Have you looked at people who do not have a spinal cord injury but have the characteristics of metabolic syndrome to see the incidence of this?
Oh yeah, there's a ton of data. I guarantee you it's confusing. Probably the best thing to say is it's really not clear at all whether mild sleep apnea is a risk factor for components of the metabolic syndrome, or if treated, will these things get better? There's nothing that is absolutely carved in stone, but for patients with more severe sleep apnea, there's pretty good data. There's excellent data that if you're hypertensive, treating your sleep apnea will improve your blood pressure control. There is some evidence for a little bit conflicted, but only for people with more severe sleep apnea that blood sugar control can improve as well. That's my take on the literature.
How does this overlap then with some of the cognitive issues? When I think about sleep apnea or some of the problems with problem-solving confusion, stuff that comes up, are you doing a measure? Do you expect it to
There's nothing in the questionnaires that's going to give us much insight into that. We didn't put it into the protocol, but that would be a nice spin-off study. We could dovetail on with, how would you like to fill out a couple more questionnaires? And, as long as you're doing this, we could, maybe come up with another study and get into it. I think the big story really is, sleep apnea as a risk factor for winding up with a spinal cord injury. I think that story is just ready to be told.
I think the other big issue is compliance.
Yeah.
the healthy injuries associated with that?
Yeah, I'll give Marty all the credit. I didn't think about that. You cringe, but I think that's one of the best parts of the study.
Okay.
When I first drafted this out and I showed it to Marty, it was his suggestion that maybe we could look at compliance as well. And I thought, it's a little touchy for a curmudgeon like me, but yeah, I sort of saw it. And the more I think about it, and I started thinking about how different the issues are with somebody with a spinal cord injury and how anything we come up with is news. I think there's a real opportunity there, but the question period, I guess, could go both ways. So my question for you, Marty, is you've dealt more than I have, with the behavioral aspects of these kinds of things, and it was your question in the first place. So I can't predict. Can you predict? Is it going to be equipment related? Are people going to be more or less, with a spinal cord injury, as I said, is somebody with a power wheelchair and 12 other pieces of equipment in the home, are they going to be more or less inclined to embrace this as yet another thing that they should do, or?
People who are clinicians here can answer that. I'll let
Probably Tony, myself, and
But you see this data too. Okay, I'll let anybody answer this. I don't
One of
know.
you'll see in their newsletter, it says, do you have that sense of control? Can you take it off? And do you want something else on your face? Are there other options there? I think in terms of, do you have that sense of, is this going to make a difference? And where are you with that decision? If you've gotten to the point of whatever's going to help and really see that as helping, I think they would. But I'm not sure if everyone thinks that way or if they make each decision about health and about compliance individually.
Okay. And I have to ask the obvious too. We've got a world's expert here. Armando's in the position that he's the one listening to the patient when the BiPAP gets put on the first time in every single case. So, well, we have an N of 1 here, but and I would like to hear his take on it too. But he not completely an anomaly, but he has enough upper extremity control that he can manipulate the mask. And between the two of you, I want some input.
Well, and and the other difference with you, you're knowledgeable. We're talking about the pathophysiology. You can understand it because of your training. You understand the impact to a much higher level.
By not knowing about it, initially, what my wife was saying, I just blew it off. Well, I don't feel it bad. But retrospectively, she pointed out, I would fall asleep at the computer during the day.
Yeah.
And, I didn't really attribute that to anything other than maybe some boring stuff that I had in front of me on the computer.
The other is,
something else. I'm gaining weight before I've been losing weight.
yeah. I think that some of the psychosocial issues that Michelle brings up are valid and we may see some of that. But another thing that we commonly see, especially where we have patients who are higher cervical, who are just going through the weaning process, who are on positive pressure ventilation during the day or at nighttime, they don't have any expiratory muscle force at all. And they tend to experience feeling smothered, both by positive pressure and also just breathing through a tube. So I think that for some of those higher cervical patients, some of the issues related to compliance is going to be related to actual physiological issues related to their very limited expiratory.
And as the question relates to the equipment component of compliance, that's something that we'll be able to deal with. There's enough flexibility in the grant. One of the issues that people always have about BiPAP is they don't like the sense that they're exhaling against some resistance. Mm-hmm. And the way BiPAP works, no matter how you trick it out, you can't get down below, about 4 centimeters? And for some people, that's just too much. Mm-hmm. And the way around that is to just use another mode of ventilation besides BiPAP. You can use pressure support or even volume ventilation non-invasively, and set the expiratory pressure at 0. And, we have that opting out arm of it, that if we can't, we're going to follow up on not only their compliance, but whether the treatment goals are within target levels. And if they're not, we can switch them to any kind of ventilation we need to get them to target. And if we find that we're switching people because of the, or compliance relates to the expiratory pressure rather than the inspiratory pressure, that tells us something.
Will you be following up about compliance and asking why you weren't using this and then switch or address those issues?
Not part of the formal protocol. We didn't put that in as to,
I think you did anticipate these issues, but I think our experience clinically is that's going to be a difficult issue.
I love that you have objective data on that. That is so exciting to me as more of that health psych background. And just the ways you can help people problem solve about not using it or why they do. Just to get things in their mind. My mom uses the CPAP at night, and she didn't use it for 2 weeks because it was too much of an effort to go and clean it out and desterilize the water each night, and it just became one of the other steps that became almost too much of a hassle. even though she knows it may be useful, or, and being reminded about that, or the problem solving of the little things, nothing big that got in the way, but.
One of the most useful tools is actually having the data downloaded.
Right.
And, you know, when we go in and say, are you using the BiPAP? Oh, yeah, almost every night, almost all
Right,
night
the
long.
social desirability.
You know, and then I have a bar graph I could just show them. They go, oh, you know, so when they're busted like that, that gives them the kind of feedback, you know, and quite honestly, from the standpoint, you know, I want when people have, on one hand, when the study shows that BiPAP is indicated, I want them to use it successfully. On the other hand, you know, our only shot at having some kind of controls are the patients that, you know, don't meet targets or refuse. So, you know, from the standpoint of the study, you know, it's going to help us to have some non-compliant patients. So, you know, there is a certain tension there. I want everyone to be compliant as a clinician, but as an investigator, the data is going to go a little bit better if the reality is that not everybody.
But it might be helpful to explain the non-compliance in that group. So
Right.
having
Yeah.
the questions, why aren't you using my baby? And the other
Yeah.
thing, I'm assuming you'll have like some kind of a parameter in terms of what do you consider is enough of BiPAP use, how many days or how many hours they have to use, so that they at least meet that requirement.
Yeah, you know, it's, there we could sort of, you know, what a lot of people do is that they look at their data and they define success conveniently. Not that we would ever do that, but, you know, the standard in the compliance literature for BiPAP is 4 hours a night for 70% of nights. You know, that's a hurdle that's that high to clear. And there's no rationale for it because all the data on the benefits of BiPAP should treat it as a continuous variable. You know, a little bit of BiPAP has positive effects, and it's not like there is a threshold effect. So why we're locked into this 4 hours a night, you know, we can analyze the data in a categorical way, declaring, you know, different levels of use as compliance, and, you know, seeing where, you know, some of these things have predictive value. We can also treat it as a continuous variable and look at the association, you know, what correlates with hours of use.
And so the next step after you're done with this, from our perspective, health management, is do we add a health behavior intervention on top of it to see, you know, then does that make a difference in terms of compliance, especially if there's already a mechanism for gathering objective data.
Yeah, exactly. And with respect to, you know, the optimal interventions, you know, from the general population, you know, the conclusion is, you know, almost predictable that, you know, the more positive feedback and immediate feedback you get from caregivers and clinicians that this is a good thing, congratulations on doing this, you should do this more, the more compliant people are. But, you know, it sort of describes the environment that a lot of spinal cord injured patients are already in.
But I think what I found with the spinal cord injury and the health is that there are so many possible things to focus on that it's hard to be up on everything at the same time. I mean, you do get that, but it's almost like, what's the issue now?